Hi, I'm Susan Stutzman, and I am the co-owner of Play Therapy Toolbox. I'm a registered play therapist, and today we're talking about play therapy in non-conventional spaces. And recently I've read through the Play Therapy magazine, and I came across an article about playing in a hospital setting, and I thought that it'd be really great to interview the author and just ask a few more personal questions. So today I'm joined with Sara Loftin from Dallas, Texas, who's a registered play therapist and wrote the article in the APT magazine, Bringing Play to the Patient. Hi, Sara.
Hi, thanks for having me today.
I'm so glad that you could join us. I would love to just ask you a few questions because I know that the hospital is a setting that really needs play therapy, but I don't know much about it. So, can you walk me through a day in your life as a play therapist in a hospital setting?
Definitely. It's definitely busy, but it's also great. So I can just tell you about my day today, actually, for example. So I worked at 9, I had an outpatient session.
Okay.
And then at 10, I had a meeting to collaborate about a patient that I'm working with pastoral care, actually.
Oh, okay.
And then at 11, I saw an inpatient who was admitted on one of our floors. And then meeting with you guys. Or at 12, I saw another patient that was actually in the hemodialysis unit.
Hmm.
Um, so he was here for an outpatient clinic appointment, but I saw him at his bedside or chair side. The meeting with you guys. And then at 2, I have an outpatient appointment with another patient, and at 3 with another. And so diagnoses can range from cancer, ulcerative colitis, end-stage renal disease,
Hmm.
heart conditions.
Mm-hmm.
So I see kiddos from the entire spectrum, but all are chronically ill, and typically
Okay.
they're pretty sick. So because I'm the only registered play therapist here at our hospital currently,
Mm-hmm.
I save those spots for kiddos who are really in need of an intervention, and then I refer those out that can be seen out in the community, for example.
So that kind of answers my next question, but I'd love to ask you a little bit more about that. Um, you are hospital based and you are employed by the hospital. Is that
Right.
correct?
Yes.
So you don't see clients outside of a private practice, but can hospital based play therapists work outside of the hospital and then see clients in the hospital and then see them after they leave the hospital, or is that not typical? Is there a typical
hmm
hospital play therapy position?
So I think your question's twofold. So you're wondering if people like therapists out in the community can see their clients when they're admitted in the hospital.
Yeah.
So
Hmm.
as far as I
Possibly
know,
like a traveling play therapist.
right. I think that would be amazing and I would love for that to happen, but I don't think that's possible
Mm.
because they're not contracted with the hospital. So for example, if I'm seeing a kiddo who for some reason goes to another local children's hospital, I wouldn't be able to see them there because I'm not
Oh, yeah.
contracted with that hospital.
Hmm.
Um, so therapists can't come and see their kids when they're admitted. Unfortunately, I think they can come and visit maybe, but that's kind of a whole other boundary
Yeah, yeah,
presentation.
yeah.
But as far as providing therapy, they wouldn't be able to. Something a therapist could do is get in contact with psychological services wherever their child is admitted. So get a
Mhm.
release of information from the family to be able to talk to the whoever's working with their kiddo here. And if they think that their patient really needs to, or their client, we call them patients because they're here at the
Mhm.
hospital. But if they think their client really needs to be seen by someone while they're admitted, then they could get a release of information from mom and then contact the hospital and contact psychological services to try and figure that out.
Okay.
Um, so as far as so I am employed by the hospital.
Okay. So
Typically,
like, let's say, I'm sorry, I cut you off.
you're forgiven. So typically, there aren't a lot of play therapists in the hospital setting. I know that I did a presentation at the APT conference in Minnesota a couple of years
Mhm.
ago. And I asked the entire audience, and I did the presentation with my friend Crystal Wilkins. We did it on medical anxiety, which is a big deal in the hospital setting, but also in the community. And there was one other play therapist, and she was in Saudi Arabia. So there just aren't, I know of a couple. There's, one in Fort Worth, but that's just not a typical position in a hospital setting. Now, hospitals typically have psychologists, and psychologists can also become registered play therapists. But what I'm finding is that there are clinical therapist positions. So my position is a clinical therapist position.
Okay.
But my specialty is play therapy. And typically all of the patients that I see are play therapy patients.
And is that because you're in a children's hospital? So your specialty is play therapy, or if someone was looking for a job or interested in becoming a hospital-based play therapist, they would typically, if the hospital wasn't a children's hospital, they'd be looking for a job under the psychology department. Is that correct? Or
right?
Okay.
I think even at a children's hospital, then you would look for like a clinical therapist position, and kind of express your specialty in play therapy through the application process, if that makes sense.
Yeah. So I'm curious, just because I know that as therapists, when we are getting training and looking for jobs or thinking about possibilities in jobs, can you share a little bit about the typical range of salary that a clinical therapist in a hospital-based setting may expect to earn? And we're in 2019 right now, so kind of like in that ball.
Yeah, definitely. So I think it definitely depends on how long you've been here. They're real big on retention, and so the longer that you've been here, the more obviously you'll make than a newcomer. But I'd say typically like 55 to 75,000. But we also have great benefits, and there's PTO. So there's a lot of things, because I did private practice for a little bit too. And so I kind of, there's like benefits, pros and cons for both.
I bet. Well, I'm curious what your favorite part of the job is and what the hardest part is, being a patient care registered play therapist, clinical therapist in a hospital setting.
I think, I love this question. So I love my job. I think my favorite part, Whew.
That's so important.
This question would be awkward if I didn't. So I think that my favorite part is to really partner with patients through this huge struggle that families never expected to have to deal with, and to really be able to be there for parents and to be there for their families. I mean, they really invite you into the most vulnerable times of their lives. And just being able to see progress as well, and building that relationship with the patient that, they don't trust a lot of people in the hospital. And so to, usually be that person that they can trust and cling to and rely on is really exciting. The hardest part is definitely losing patients. When patients pass, that is the worst thing about my job by far. Definitely the hardest.
So when a patient comes into the hospital where you are working, then they are terminally ill. So you work with them from the point that they come in to their death. Is that correct?
So it depends. I mean, not every patient dies for sure, because I save those spots. Within our hospital, just kind of backtracking, but we have psychiatry, and then under psychiatry, we have psychological services. So there are various clinical therapists and psychologists throughout the hospital. So we have psychologists that are just for hematology, oncology, and then we have clinical therapist psychologists for pain management. So I'm on the consult team, which means that I can see patients from all over the hospital. So because I do play therapy, which a lot of other people don't do here, then I do save those spots for the ones that really need it. And because of that, I do see kiddos that are more sick than others from time to time.
Okay.
So definitely not every patient that I work with passes. I don't think I could stay in this
That would be
if that were
intense.
the case. But it definitely is something that happens. And even in that, it's such a beautiful moment to be able to share, that families invite you into that time in their lives too. And so there are really beautiful moments, but it is really sad at the same time.
Yeah. So what does a typical play therapy session look like in the hospital setting? Can you give me time, how many times a week, and then also like what you would bring in, what a kit looks like?
Definitely, yeah. So I do see outpatients and inpatients, which is nice. So we have a playroom here. I'm signaling over there because it's right next to me. That it's nice to see kiddos on an outpatient basis. So those kids I see once a week, 45-minute sessions, depending on their age. If they're younger, like a young 3, then I'll do 30-minute sessions. And then for my kiddos who are admitted on the floor, and so that also means that if I see a kid outpatient and they're admitted, then I'm able to see them inpatient as well. So for those kids,
I'm sorry, but just so that I understand, if they're coming outpatient, is that because they've been referred to the hospital, or that they've been inpatient and now they're coming outpatient? Like, how does that work, that they come outpatient to you?
Yeah, so all my referrals come from children. So whether so Children's is our hospital, Children's Center. So whether that's the doctors or nurse practitioners or psychologists that have seen patients, or they just know that play therapy would be a better fit. So that's where all my referrals come from. So, it might be that they're having a really hard time in clinic. Say they're a kiddo with leukemia, and they have a lot of medical anxiety, and they, have a lot of anticipatory anxiety before the appointment. They don't bounce back. They have a lot of residual anxiety after. Then that's the kind of referral that I would get. So even if they're not admitted on the floor, then I'll start seeing them outpatient.
But they're coming to the hospital for some sort of service, like
right, exactly,
cancer treatments or something.
Right. Okay. So they're already patients here.
Okay.
So my kiddos who are admitted, go ahead.
No, I was going to say, and then the admitted. Sorry, because I cut you off. I just was like, I'm so interested in this.
Yeah, no, ask away. I don't mind. My patients who are admitted, I try to see them 2 to 3 times a week for about 30-minute sessions.
Okay.
If they're really, really sick, then sometimes my sessions will be like 15, 20 minutes. It's all kind of what they can tolerate. And what that looks like. So I've got a kit that I can show you guys.
Awesome.
Yeah. If you can see it. So here's kind of a kit that I would bring to an inpatient floor and to see a kid who's admitted. So what's important is that we have infection control. So this is, one patient's bucket, and this will be their bucket while they're admitted. So no one else, I don't ever take these toys out. So that is what that looks like. And so I've got some toys in here, some like sensory toys. And I know I mentioned this in my article, but it all depends on the patient's abilities too. So, I've seen patients who are paralyzed, who are mute, who may be deaf or blind. And so depending on that, it would change what I might bring into the room. So if I'm working with a patient who's blind, maybe because of where the brain tumor is, then I'll bring in stuff that's really tactile or that's smelly. Like smelly markers are always a good choice. These are a really great way to connect with kids at any age, even teens, I'm telling you. And then, I would bring in like Play-Doh, lots of Play-Doh. But so I like to bring in toys that are with each kind of category of toys.
The three categories that Gary Landreth talks about.
Yeah, good old Gary Landreth.
So kind of like in my traveling play therapy kit, it's like you have the nurture toys, you have the aggression toys, and
exactly. Yeah. So we've got aggressive here. Yeah. Lots of mastery and creative toys. So we've got like real life toys, like a doll family. And then I would bring in things that depend on what the child may be working through. And so this child is or a kit that I would bring to see a kiddo like this who might be NPO, which means they can't eat. And so this has different like food cooking items and food items. Kind of work through that. And then there's some relaxation stuff in here as well. So we've got a pinwheel. So this might be for like a 7-8-year-old boy, for example.
So you mentioned that you, thank you so much for sharing that. You mentioned that you don't change up the toys or while they're inpatient. So you have access to their chart, obviously, before you see them, and have been asked to come and be part of their treatment plan. But how do you go about choosing that? And do you have just a number of categories that you can just pick from as you create these treatment buckets or play therapy toolboxes, for lack of a better word?
Yeah, I think that's a great question. I feel like sometimes I kind of feel like it's muscle memory at this point. Like sometimes I get a kit and I'm like, oh, this is great. Like sometimes I don't even kind of remember putting everything in there. But I do kind of have go-tos. So my go-tos are always going to be like paper, scented markers, a stress ball or pinwheel or bubbles of some sort, or all three. So, and then that aggressive play, that dart gun, the kind of foam launcher is always a good one to bring. So I definitely have like a base that I use for my play kit, and then I add to it as I see fit, depending on what the patient's kind of going through. That's a good question.
And then just one more. I know in the Playing in the Home workshop course that Lisa, Deanna, and I recorded, we talked a little bit about when you're in unconventional spaces, sometimes it's helpful to have like a boundary marker. And so when you're in a home, sometimes like laying out a blanket or putting toys around to create kind of like a barrier. How do you do that in a hospital setting? Because I imagine there's different varying degrees of mobility in children. And so being a mom myself, I could just imagine, if one of my kiddos was in the hospital and they had more mobility, they might want to be like, oh, there's a breathing mask. I could try that out, like just pulling stuff if it's like, hey, it's playtime. So how do you set those boundaries and limits?
That's a great question. I feel like most of the kids that I see who are admitted are on some sort of IV pole.
Okay.
So there's kind of a boundary that's already set up. Just the patient's bed is typically our boundary. They're typically not super mobile. I have worked with kiddos who maybe have been disconnected from the IV pole because they don't need it at that time or something. And, PT and OT have really been working with them with getting out of their bed. And so we have set up like a blanket on the floor for us to sit down and sit on the floor and be able to play. So I think that would be, but typically it is just their bedside.
Okay. Well, that's great. Yeah. I'm curious, is there anything else that we should know about playing in a hospital setting and doing play therapy with children that are in a hospital setting that would be important?
Oh, how much time do you have? I will say if this is something that people are wanting to do, it is very hard to kind of climb your way into this setting. But it is so rewarding and so wonderful. And so I will say to really start getting experience in the medical setting, because I do know if we ever hire, I think we hired one clinical therapist because they are, so few and far between the times that we do this. But if someone didn't have hospital experience, then we wouldn't even look at them. I know that I have an internship actually that I supervise. And so whenever I have interns that even apply, even for my unpaid internship for people that are still in grad school, if they don't have medical experience, then they don't get the internship either. And so I think it's just getting that medical experience before really pursuing something like this, I would say. And you can do that through camps. So it's just working with children with chronic illnesses. So there are different camps that are out there. Then there's also just volunteering at your local children's hospital can be something that's helpful too. And then just getting connected with people that are already kind of in the field.
Yeah. That is so helpful. And where did you get your training?
So I went to UNT for grad school.
Nice.
Yeah, so I really loved it. It was a wonderful experience. And I actually did my master's level internship here at the hospital.
Oh,
So I
wow.
started as a master's level intern, and then I stayed on as an LPC intern post graduation. I speak Spanish, so I think that's really helpful, especially
Yeah.
here at a children's hospital in Dallas, Texas.
Mhm.
Very needed. Um, and so, and then I stayed on as a fully licensed counselor as well. I've been very lucky to be able to be here for as long as I have been.
That's wonderful. Wow. And to have the experience from UNT and wow, who was your supervisor? Just out of curiosity.
Well, so I had lots of like various supervisors. Are you talking about when so I've worked with Sue Bratton a lot at
Yeah.
UNT.
Hmm.
She's been really wonderful. I did like a research project with her after I graduated. So I've worked with a lot of them and still do. My intern that I just had just came from UNT as well. So trying to stay connected with them because they do such amazing work and they put out a lot of the research. And that's actually something else that's really interesting because I can remember getting my degree and people talking about research and me thinking, oh, that's just not for me. Research is so boring. But being in the hospital setting, I see how vital it is,
Yeah.
and how sometimes people won't even pursue a treatment if it's not evidence-based. And so I even do pre-follow-up and post-assessments with the families that I work with to really assess, just for quality improvement,
Hmm.
to really assess how things are going and if they've seen progress. And so it's just so funny how often we think so negatively about research, but how vital it is for the growth of play therapy to continue.
It's
So
true.
that
Yes.
it really is.
I love it. We got to raise that flag for
I know
research
we
because
need
I
more
think
research focused people.
it's so true. And it's really important because it truly works, but we can't just rely on secondary research too. I know one of
Right.
my favorite things to do is to, quote different people in the neuroscience world that
Mhm.
talk about modeling, such as Dan Siegel and
Oh,
Stephen Porges and Bessel van der Kolk. But we need to also be promoting and doing research on those same topics and different
right.
things that are happening for children. So
Right, exactly. And I know that CPRT is now evidence-based, which is really exciting.
amazing. Yeah.
So we actually do CPRT groups here at the hospital too. So
Oh,
one of my
wow.
coworkers, Bridget Redondo Jones, she's an LPC and an LMFT.
Hmm.
She and I do one group in English every fall and then Spanish every spring, and we're able to offer that for free and have free childcare. It's just a wonderful resource. So
Wow. Well, Sara, it sounds like you're doing such amazing work. Thank you so much
oh,
for
thanks.
all that you do and all of the families that you bless. Thank you for being part of this interview and for writing an article, continuing to add to the research pool.
Fingers crossed.
And I appreciate the time that we've been able to spend together. Thank you to all of you who've been able to watch this and stay until the end. We hope that you've enjoyed this and found this really beneficial for understanding more ways to do therapy in non-conventional spaces. Also to be able to have reference and resources for your clients or other individuals who may be seeking treatment when they're in a hospital setting, so that you have the reference and the referral sources to be able to share as well. If you want any more information on Sara Loftin or her work, that information can be found in the links below, as well as in the APT journal article for in 2017. But thank you again, Sara, and I wish you all the best. Bye.
Thanks. You too. Bye.